Namaskar sabhi ko. A very good evening to one and all. I welcome you all of you on this virtual celebration of 8th Ayurveda Day from on behalf of Ayurveda Welfare Foundation and Ayush Darpan Foundation. Myself, Dr. Shilpa Yerme, and I am the coordinator, organizer, and host for today's session. So, on behalf of our team, I welcome you all. As we all know that we are celebrating this year, this Ayurveda Day based on the logo, yeah, based on the theme Ayurveda for One Health. Ayurveda every day for every पर ईयर या जैसे हर घर हर दिन आयुर्वेदा, इस थीम को लेकर हम लोग इस साल वसुधैवकम कुटुंबकम इस थीम के अनुसार हम आयुर्वेदा डे का सेलिब्रेशन करते हैं। और आज ये हमारा पहला सीजन है, पहला सत्र है, जिसमें मैं हमारे सभी आदरणीय स्पीकर्स का बहुत बहुत स्वागत करती हूँ। और आज का सत्र हमारे साथ उपस्थित है वैद्य आसमा खान एंड आई वेलकम यू डॉक्टर आसमा। बट सबसे पहले हम धन्वंतरी वंदना के साथ इस सत्र का आरंभ करते हैं। सो आई एम शेयरिंग द धन्वंतरी वंदना।
शंखं चक्रं जलौकां दधतमृतं घटं चारुदौर्भिश्चतुर्भिः सूक्ष्मं स्वच्छातिरुद्यं शुकपरिविलसनं मौलिमम्बोजनेत्रं कालाम्बोद्योज्ज्वलाङ्गं कटितटविलसश्च चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तव निखिलगदमिव प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्।
आयुर्वेदा डे को केवल भारत देश में ही नहीं बट दुनिया के 100 देशों में इसको मनाया जाता है। और माननीय पंतप्रधान नरेंद्र मोदी जी की संकल्पना से ही इस आयुर्वेद डे का आरंभ भारत देश में हुआ है। और आज ही हमारे लिए बड़ी गौरव की बात है कि हम इस दिवस पर बड़े पैमाने पर सेलिब्रेट कर रहे हैं। हर घर हर दिन आयुर्वेद, यानी हर एक वैद्य इस आयुर्वेद के प्रचार एवं प्रसार में जुड़ा है। इस साल 10 नवंबर को हम इस दिन को मनाने वाले हैं। तो चलिए ज्यादा समय ना बिताते हुए आई वेलकम डॉक्टर आसमा, जो कि औरंगाबाद महाराष्ट्र से है। एंड हर टॉपिक इज रोल ऑफ पंचकर्मा इन इसेंशियल हाइपरटेंशन। सो वेलकम डॉक्टर आसमा एंड यू कैन स्टार्ट योर प्रेजेंटेशन।
Is PPT is PPT is visible, ma'am? Hello?
No. It's not shared yet. You can try once
Okay.
again.
Okay. Now?
No.
Okay, एक minute. Okay, एक minute, ma'am. एक minute. Ma'am, there is only the host can share in this meeting PPT. It's showing that.
Yeah. Okay, just a minute. अभी ट्राई करिए।
Okay, ma'am.
ट्राई वंस।
Okay.
हाँ, अभी हो जाएगा।
Okay.
आपके पास 10 से 12 मिनट का समय है। यस।
Okay, ma'am. Now
नो मैम, नो नो
it is visible.
नो
No.
नो। हाँ, उसको बंद करके एक बार फिर से शेयर करिए।
Okay, ma'am. एक मिनट। एक मिनट। Okay.
नहीं हुआ शेयर अभी तक।
PDF. Oh, ma'am, actually, एक मिनट। Now
नो नो नो।
I don't understand. Okay, now
नो 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 नो।
now.
नहीं हुआ है। मैं शेयर कर देती हूँ, आप कर लीजिएगा इसको, ठीक है।
Okay, fine. Okay, fine. Okay, ma'am.
यस, यू कैन स्टार्ट।
Now it is visible, ma'am.
यस,
PPT is not visible.
है, दिख रही है, विजिबल है।
मैम मुझे विजिबल नहीं हो रही है।
नहीं हो रही।
नहीं।
शशि, आपको दिख रही है? डॉक्टर अर्चना, आपको दिख रही है पीपीटी?
मैम पीपीटी नहीं, बट कुछ डिस्प्ले तो हो रहा है। दिस इज लाइक, अब इसको
हाँ,
ऑन करेंगे तब दिखेगा।
अभी तो मैंने किया है, मैक्सिमाइज
मैम
किया है,
होस्ट बाय।
क्योंकि उन्होंने पीडीपी आपने पीडीएफ बना दिया पीपीटी का, तो वो ठीक से शेयर नहीं होता है।
मैम PDF के लिए एक मिनट में PPT।
आपके नहीं, आपके पास जो भी है ना, उसके साथ आप बोल लीजिएगा ना, जो भी आपके मोबाइल में होगा, जैसे होगा आप बोल लीजिए। अभी मैंने तो शेयर किया,
ओके।
मेरी तरफ से जो भी पीडीएफ भेजा है उसको मैंने शेयर किया है।
नहीं मैम, एक्चुअली वो नहीं हो रहा है। मैम गिव मी दैट।
दिस इज रिटन दैट इज पीके इन ईएचटी और मेनोपॉज, ये सब इस तरीके से पूरा मतलब एक।
बैक टू मीटिंग। मैम एक्चुअली ओपन ही नहीं हो रहा है।
अच्छा,
आपकी स्क्रीन का तो बिल्कुल नहीं।
एक बार फिर से करती हूँ।
कुछ प्रॉब्लम आया है।
अभी
Is it I am visible? Yes. First page now.
यस नाउ ओके।
Yes. Now it is visible.
यस प्लीज।
Uh, all of you, a very warm welcome on the Ayush Darpan platform. I'm very much grateful to Dr. Shilpa ma'am and Dr. Naveed Joshi sir that they had given me the opportunity to talk for Ayurveda. It's 8th Ayurveda Day on this Dhanatrayadashi. We are celebrating Ayurveda for all health, and the topic is myself, Vaidya Asma Khan. My topic is role of Panchakarma in in uh, arterial hypertension. So, ma'am, it's gonna. Hello, hello.
यस मैम बोलो,
There
आप
is
आवाज आ रही है।
this. This is not display. PPT is not display on the screen. Hello, is I'm audible to everyone?
यस मैम।
So, my topic is role of Panchakarma in essential hypertension. ICMR and AIM study has declared that India is a nation of hypertension. Essential hypertension is one of the leading lifestyle disorder. This is the burning problem all over the world. Hypertension is called a silent killer. It show that typical symptom before the damage to heart, kidney, and the brain. More the essential hypertension is one of the risk factor of heart attacks, heart failure, arterial aneurysm, and leading to the cause of chronic renal failure. So even moderate elevation of arterial blood pressure leads to the hypertension. In Ayurveda, first essential hypertension is correlated with the next one. Correlated with the Siragat Vata, Rattagat Vata, Shonita Vikara, or Avrutta Vata. Many research scholars have studied the Sangra Grantha, but the stated at the every disease can be given the nomenclature. But essential hypertension is not given in the Sanhita, but scholars has tried to the given to the nomenclature of this disease, that is Pittavrutvat and Raktagatvat, Siragat and Dhamni Pratichay or Raktagatvat. Charkacharya has given detailed chapter on Vat dosha and Vat Vyadhi in the Vat Vyadhi Adhyayan. There they mention the Avruttavata concept. In that Pittavrutvat is one of the we can correlate with the essential hypertension. Next one. So uh, uh, prevalence of hypertension, you can see that hypertension is most common clinical condition. Approx 80 to 85% of hypertensive patients have essential hypertension. In more than 95% of case, specific underlying cause of hypertension cannot form such a patient are said to have essential hypertension. You can see that about 26.4 of the world adult population in 2000 had hypertension and 29.2% projected to have this condition in 2025. It has been estimated that hypertension occurs 6% death per year. Next one. So hypertension, you can see the definition of hypertension. It is said that the hypertension, we can find that blood pressure is persistently high in the arteries. The higher the pressure register, the harder is the heart has to pump. So hypertension is name given to the condition where the reading of high blood pressure remain high and above normal of the time. The means that hypertension, the blood pressure of the person is high in each and every time it is measured consistently elevated. So, how to understand the blood pressure reading? There is a first reading was the systolic blood pressure, and second reading is a diastolic blood pressure. Types of hypertension. Second one. Types of there are the ranges of the hypertension. Range of blood pressure is defined as an American Heart Association given the ranges of heart hypertension. Normal blood pressure is 120 by 80 mm of Hg. But pre-hypertension phase, you can see that is 120 by 139 of mm of Hg. Then stage 1 blood pressure, hypertension systolic blood pressure is 140 by 159 mm of Hg, and diastolic is 90 to 90 mm or 99 mm of Hg. Stage 2 hypertension blood pressure is that 160 above hypertension systolic and above 100 is diastolic. Hypertensive crisis when it is occurred, that is medical emergency, that is 180. In hypertension, natural variation of blood pressure, you can see blood pressure lowers at sleep and rise at awaking. Blood pressure naturally rises during anxiety, excitement, and following physiological activity, just like exercises and while you are doing heavy exercises. Type of hypertension is primary hypertension and secondary hypertension. Primary hypertension is an essential hypertension that did no cause is given, and then the secondary hypertension is caused after the some time period where the persistent raising of the blood pressure is occurred. Some of the other diagnoses you can see there are some of the other terminologies used for the different type of diagnosis, that is white coat hypertension. Many times patient get nervous and clinical leading to eradicate and reading. Fear factor of the in the hospital, patient get a white coat hypertension. Mass hypertension is exactly opposite to the other hypertension. That opposite to above normal during activities. But when the patient is in the clinic and come to the hospital, there is a normal range of systolic and diastolic blood pressure. But when patient is out of the clinic, that is they are raised in the blood pressure. And there is pseudo hypertension also another diagnosis in elderly non-compressive artery syndrome caused due to the calcification of artery resulting in high reading cutoff and intra-arterial measurement of BP are normal. That is last one is orthostatic hypertension. BP increases upon standing. When patient is standing in the and you are taking the blood pressure, this hypertension is seen. Pulmonary hypertension you mostly seen in the ICU patients. It's a rare lung disorder. Here the pipes carrying blood from the lungs is narrowed, make it difficult for blood to flow through the vessel. Blood pressure in this artery is called pulmonary arteries. And another one is pregnancy induced hypertension. This hypertension is mostly seen in the ANC patient, which is 20 weeks above pregnancy. You see the female patient having the hypertension, induced hypertension. And renal hypertension is another one. There is a narrowing of the renal artery from the heart, which is carrying from the heart to the kidneys. And there you can see the renal hypertension increases in the CKD patient also. Symptoms of hypertension you see, that is headache, nausea, feeling of burning sensation, vertigo, vomiting, feeling of tiredness, restlessness, and loss of appetite, pain in chest, discomfort, bleeding from nose, swelling in the lens and under eye. And in Ayurveda, it is given that in Charak Chikitsa 28 Adhyaya, Lingam, one of the basic symptoms in the Pitta Vruta Vata, that is Lingam Pitta Vruta Daha Shula Brahmastama. That is typical symptoms like in modern they are explained, that is there is a headache, there is a vertigo, there is a dizziness, patient feeling burning in the chest, patient feeling discomfort in the chest. That is a typical symptom of essential hypertension. So in laboratory test we can monitor the 24-hour BP essential में 24-hour BP monitoring, blood sugar, kidney function test and lipid profile. And in desirable things, if you want, then you can do hemogram, serum creat, serum electrolyte, complete urine analysis, electrogram, and X-ray of the chest. Next one. Ayurveda management, there is a Sanshipita Kriya Yoge, Nidanam Parivarjana said by the Sushruta, said that Nidan Parivarjan, that is avoidance of etiological factors, lifestyle modification. And third one is Shamana, treatment the following drugs, single compound formulation we can use to treat the hypertension. Here is I had given some of the names of the drugs which can use in the hypertension in the primary stage. Single drugs, that is Sarpagandha Churna, Ashwagandha Churna, Jatamasi Churna, Arjun Choka Churna, Rasna Shirpak, Rasona. And compound formulation you can use that Sarpagandha Ghanavati, Brahmi Vati, Prabhakar Vati, Arjuna Rishta, Pravala Pravapishti, Swet Parpati, and Nagarjuna Bhar Rasa. Other drugs which have been the property of antihypertensive, that is Karpurvalli, carrot, flax and seed, tomato, drumstick, tulsi, buyamlaki, pomegranate, radish, sesame, wheat bran, you can use. Rasayana like Brahmi, Ashwagandha, you can use Brahmi, Manduktarni, and Rasayan can use in the hypertension to treat the hypertension. Next one. Significance of Panchakarma in essential hypertension is one of the most important things. That is, Sanshadhan Chikitsa is specialized therapeutic approach of eliminated toxins from the body and biocleansing procedure. That is Panchakarma. It is usually followed by the Shamana Chikitsa and however decided by the physician according to the patient's convenience and whether the Shodhan therapy is indicated or not. There, Basti as a specific verified medicated enema. In this, Rashmul Nirovasti and Lagu Panchamul Nirovasti is one of the basic vastis you can use in essential hypertension. Vireshan Karma you can also do with the castor oil. Shirodhara with medicated liquids, takra, milk, butter you can use. And in Rakta Mokshana, that is Siraveda, you can use when the patient is coming to your OPD at an emergency phase. You can do the Siraveda. It is having fantastic result in the lowering the hypertension at an emergency case of management. Next one. You can use Takradhara, Tailadhara, Jaladhara to reducing the etiological factors of the patient, and also you can use next. You can use another Shiro Lepa, Shiro Basti, Shiro Pichu, for the treatment of the to treating the hypertension as per the requirement of the patient's emergency management. So the other management you can do that uh, yoga, Tai Chi, and acupuncture also you can do. Autogenic training you should give. Meditation also is one of the choice of the physician. Relaxation and breathing exercises and biofeedback. It is a technique where people are taught to the monitor his blood pressure that's normally occurring rate, and to treat the muscle tension and skin temperature to the used to treat migraine, tension, headache, and chronic incontinence. Prevention is very important because while you are taking prevention, you can be out of that hypertension. So practice pranayam, go full vegetarian diet, दिनचर्या and ऋतुचर्या, आचार रसायन, वेग विधारण, निदान परिवर्जन is very important. Dash diet is one of the new technique developed by to approaches for hypertension, that is patterned by the US based National Heart, Lung and Blood Institute of Prevent to Control Hypertension. So dash diet is rich in vegetable, fruits, whole grains and low fat dietary dairy products including meat. So this is the new technique developed by the US based National Heart Association. They give the diet. So one of the beneficial foods are ginger, and ginger you can use in that. So FAQs are very much important. This the next one. FAQs are very much important. Question arises in all over the things. That is, salt is one of the positive factors for causing the hypertension. So can hypertensive patient can take rock salt, that is Sandavlavna. So Sandavlavna is the rich in the several minerals and micronutrients. So in Ayurveda, salt preferred to the common salt rather than the you can use Sandavlavna. So you can use it in your diet. So hypertensive patient, according to the physician opinion, you can use Sandavlavna. Some of the patients ask with Ayurvedic treatment, hypertension with tachycardia can be treated. So yes, it can be treated. Sarpagandha is very useful in this regard. Pulse rate and blood pressure at the same. Sarpagandha Divati, Panchagaratna Gulika you can give to the patient. So question is always arise that can Ayurveda totally cure hypertension? So initially one has to depend on the Ayurvedic medicine. Side by side lifestyle changes such as the quitting alcohol and lifestyle disorders, lifestyle changing yoga and pranayama, you can continue with the Ayurvedic medicines. Can switch, some of the patients ask that can switch from allopathic medicine to Ayurvedic medicine be made? So it needs to be done with the strict medical supervision. It may take between 2 to 6 months. During the switching to period, it's the best for the patient to monitor the BP at home and consulting with the physician day to day. So above said information is very important that your physician know that there must be a proper monitoring of the BP. So conclusion is that recently the lifestyle is very much busy and you are continuously working and continuously in the stress, and while you are not following Trayap Stamba and Dincharya and Rutucharya, so avoid hurry, worry and curry. These are the references of WHO's and Medical Association, American Medical Association and Sahitas. And thank you. Choose best way of life, the best way of my life with Ayurveda. So I am very thankful to Dr. Shilpa Erme ma'am and Dr. Praveen Joshi sir that they have given me such opportunity to speak about the essential hypertension. And happy Dhanatrayadas, and you are happy Dhanatrayadas and prosperous Diwali to all of you.
Thank you, Dr. Asma. It was really wonderful, short and sweet. Thank you very much for your efforts. And I ask now to our doctors if any question, just one or two questions we will take. If any discussion on this essential hypertension, you may ask. If anybody wants to discuss, you can put it to the chat box also, or directly you can ask to the speaker. So thank you, Dr. Asma. I think most of the points, yes, most of the points you have covered well, and there is no doubt about this hypertension. So it's really
Okay,
nice.
okay, thank you.
Yeah.
Thank you, ma'am. Thank you. Thank you so much.
Moving forward with our next speaker, I welcome Dr. Parul Joshi, madam, who is the very well-known Ayurveda gynecologist in the field of Ayurveda, and madam is very known to us. She is retired HOD, PTSI department, retired principal and medical superintendent, and State Model Institute of Ayurvedic Science, Kolwada, Gandhinagar, Gujarat, and presently working as principal in Gandhinagar, Gujarat also. And she is a very admired speaker on various platforms. She delivers regular lectures. So welcome, ma'am, and you can start your presentation.
Thank you very much, Shilpa madam. I'm very much
yes,
thankful
easy,
to
ma'am.
Ayush Darpan. Am I audible, madam?
Yes, continue. Please continue.
Thank you, Ayush Darpan, for giving another chance to present myself on my favorite subject. According to Ayurveda, a Garbhini is divided into two groups, Avyakta Garbha and Vyakta Garbha. So the Avyakta Garbha Paricharya is extension of Rutumati Paricharya, while Vyakta Garbha is Masanumasik Garbhini Paricharya. So I would like to, since I cannot do video also and slide sharing also, so I'm very sorry, I will not be able to put myself before you. There is internet problem over here. So I'm at present Director Shada Associates, Gota, Ahmedabad, and we are working in medical field, and we are working in multiple aspects of medical field. So, and I'm very happy I'm able to share my slides. So, the pregnancy is divided into, we will talk about modern and Ayurveda together. So the pregnancy is divided into 3 blocks of 3 months each. So that is because of 3 months, it is called trimester. The first trimester is from conception to completion of 12th week. The second trimester is from 13th week to completion of 24th week. The third and final semester is 25th to 40 or 42 weeks of pregnancy. That is whenever the baby is born. The third trimester is very exciting and scary for the parents to be. The father is also worried about the outcome. So especially the first timers, the first time parents are more excited and scared. The joy of becoming a parent, it also brings discomforts and risks in the third trimester complications. So what can be done is recognize the crucial complications and recognize the well-being of the baby. So that is very much needed. How do we see that we can maintain the well-being of the baby? In the third trimester, neurons develop protective layers called myelin sheaths, and these are very important. So according to Ayurveda, we are supposed to give to the mother Yashtimadu, Turva, Kokshur, and this is all related with the development of the fetus and the complications a mother faces in the third trimester. Now, we can't talk about only the third trimester because it is totally dependent from the conception and till the third trimester starts. So, during the first trimester, whatever happens leads to developments in the second trimester, leads to development and complications in the third trimester. Now, when we are talking about Ayurveda over here, Acharya has said, Garbhopakatkar bhavaha. So, if the mother to be. Thus, sarvam atikura ushna tikshna daruna cheshtaha. Then what happens? Then development of complications to the fetus and the mother are seen. So, devataha rakshaha anuchara pare rakshartham. So, we need to ask for the supernatural or the omnipresent to protect the mother and the fetus and keep people who can protect both of them. न रक्तानि वासांसि विब्रूयान् नमत् कराणि मध्यानि अभ्यवहरेत् न यान अधिरोहेत्. But over here, they are talking about these complications and they are saying these foods are to be given and these exercises are to be done. This is just opposite of what the acharyas have said. So bhavan, all these bhavans are pratikulan. Bhavan duratah parivarjayet. So we need to stay away from all these bhavas. And this is what is being talked of. And you can see over here, the mother is wearing a belt that protects her belly from coming down. And the exercises that we are asking her to do is Utkatasana. So this both the styles lead to abortion, and Kathinasan Sevan will in the long run lead her to Arsha. The child will be born down. Premature delivery can happen. This asana can be called Utkadasana. This Mayurasana, these poses are contraindicated to Ayurveda because delivery cannot be done in this pose according to Ayurveda. So, Daruna Cheshtaha Vyavaya Adikaha. And what is advised is, see, she will not ovulate, आप sex करेंगे तो कोई problem नहीं होगी. That is not to be done because sex वो दारुण कर्म है. Devta Raksho Anucharebhyah Parirakṣanam. She needs to be protected from all types of problems which can arise from food, from her own misdeeds, or from her own infections of the past. These all can pop up at this time because she is physically, emotionally, and mentally, even psychologically, she is weak. So she needs more protection. Protection in the form of consoling her, boosting her up, giving her such food, and prompting her for such habits which make her stay away from insomnia, swollen feet, because we are giving Gokshura Yukta Dukta, Gokshura Sadhi Dukta, we call it, fatigue and low back pain. So we give her Shrama Harakarna, Braxton Hicks contractions. So the food that we give her should be Supachya, Vatahar, Vatanuloman, and Rasayan, so that Braxton Hicks kicks जो है उससे हम माँ को बचा सकते हैं. दूसरी एक बात जो यहाँ पे आचार्य ने बताई है वो उत्कट विषम कठिन आसन सेविना. उत्कट आसन तो हमने देखा, लेकिन विषम आसन भी नहीं रखना चाहिए, यानी समतल आसन पे जो मृदु है, जो सुखकर है, उसको सेवन करना चाहिए. और ये सब एक्सरसाइजेस करने के बजाय अगर मदर शवासन करती है, जो इसमें कुछ कुछ पोज जो है वो इस फिगर में आ जाता है, तो लेकिन इसमें भी कंप्लीट शवासन तो नहीं हो रहा. सीधे लेट के नहीं करना है, थोड़ा तो उसको सपोर्ट देना है, लेकिन इतना भी ऊंचा उसको नहीं रहना है. फिर तीक्ष्ण उष्ण अति मात्र सेविनिया. उष्ण तीक्ष्ण कर यानी कि हम मिर्च, राई, अचार, ऐसी कुछ चीजें जो है वो नहीं देनी है. स्पाइसेस जो है वो भी उनको नहीं देने हैं. अगर हमने किया और उसको प्रमित आसन करवाते हैं, हस्बैंड क्या बोलते हैं, तू मोटी हो गई है, तेरा मिडिल गर्थ बढ़ गया है. मिडिल गर्थ इसलिए बढ़ा है क्योंकि उसमें बच्चा है, देयर इज अ होल पर्सन इनसाइड. तो अगर आप बोलेंगे कि तेरा गर्थ बढ़ रहा है तो वो खाना नहीं खाएगी और उसकी वजह से जो है वो प्रॉब्लम होगा. और आचार्य कहते हैं गर्भो म्रियते अंतः कुक्षे, इंट्रायूट्राइन डेथ होगी, इंट्रायूट्राइन फीटस डेवलपमेंट जो है वो रिटार्ड हो जाएगा, उसके लिए आचार्य ने कहा शोषी व भवती, गर्भ अकाले म्रियते व अकाले जायते स्रंसते। अभिघात प्रबीण नहीं है, उसका क्या कर सकते हैं हम? तो उसको हम लोग आराम से उसको रखना है, उसको बोलना है आप आराम से रहो, अपने आप को जो है अपना ब्रीदिंग जो है उसको कंट्रोल करो, रेगुलर ब्रीदिंग पे ध्यान दीजिए। और जो आपका बच्चा है उसका कोई प्रॉब्लम नहीं है, डोंट फील अफ्रेड, ऐसा करके उसको कंसोल करना है, सांत्वना देनी है। तो प्रतत उत्तान शायिनी ऐसी अगर सीधी लेटती है तो उसके बच्चे को क्या होता है? गर्भस्य नाभ्याश्रया नाड़ी, यानी नाभि नाड़ जो है उसकी कंठम अनुवेष्टयति, जो हमको देखने को मिलता है। इस तरह की एक्सरसाइज हम करवाएंगे तो गर्भ की नाभि नाली जो है उसके गले के आसपास आ जाएगी, तो वो नहीं करना है। फिर विवृत शायिनी, खुली सोती है, खुले में सोती है और खुली सोती है, वहां वो अपने आप को असुरक्षित भी महसूस करेगी। तो उसके वहां पे नक्तम चारिणी, रात में जाती है, बाहर निकलती है, तो उसमें क्या होता है? उन्मत्तम जनयति, अपस्मारिण, अपस्मार युक्त बच्चा भी जन्म सकता है। कली कलह उसको नहीं करना है। व्यवहारशीला जो है वो दुर्मन, उसका बच्चा जो है वो दुर्मन युक्त उत्पन्न होता है। शोक नित्या भीतम अपचितम अल्पायुषम जनयति, तो उसको शोक नहीं करना, यानी कि घर में कोई ऐसा बना हुआ है या वो कुछ ऐसा देख चुकी है तो उससे उसको बाहर निकालना है, वरना उसके गर्भ में ये सब प्रॉब्लम हो सकता है। बच्चा जो है भीरू आएगा, वो कृश, उसका बॉडी कभी बढ़ेगा नहीं और उसका आयुष भी जो है अल्प आएगा। क्यों? क्योंकि उसका वायु जो है बढ़ा हुआ है। फिर अभिध्यात्री परोपतापितम ईर्ष्यु श्रेणम च, ईर्षा युक्त महिला जो है उसका बच्चा जो है वो परताप में अपने आप को सुखी समझता है। वैसे एक पूरा लिस्ट दिया गया है। तो मधुर नित्या प्रमेहिणम मूकम अतिस्थूलम अम्ल नित्या रक्तपित्तिम त्वग अक्षि रोगिणम लवण नित्या शीघ्र वलिपलित खालित्य रोगिणम कटुक नित्या दुर्बलम अल्पशुक्रम अनपत्यम वा जनयति। तिक्त नित्या, यानी जो महिला इस तरह का एक रस सेवन प्रायः करती है या अधिक मात्रा में इन रसों का सेवन करती है, तो शोषिणम अबलम अनुपचितम वा जनयति। कषाय नित्या श्यावमाना हीन मुद वर्तिनम वा। ऐसे ऐसे जो जो व्याधि को उत्पन्न करने वाले निदानों का हमने वर्णन किया है, वे सभी जो है निदानों का सेवन करने वाली महिला जो है उसका बच्चा जो है वो उस रोग से पीड़ित आएगा, यानी कि सहज व्याधि लेके आने की संभावना होती है। तस्मात् अहितान आहार विहारान प्रजा संपदमिच्छन्ति स्त्री विशेषेण वर्जयेत। जो अपने आप को स्वस्थ संतान युक्त बनाना चाहती है वो इन इन चीजों को छोड़ दे। साधु आचार च आत्मानम उपचरेत, अपने आप में जो भी अच्छा लगता है, यानी कि मेरे बच्चे में ये गुण मुझे चाहिए, ऐसा जो महिला सोचती है उन उन आचारों को वो नित्य अमल में लाए। कौन से? तो आहार विहाराभ्यम, तो ये महर्षि चरक शारीर स्थान में बताते हैं, अध्याय 8 में, यानी कि शारीर स्थान का अंतिम अध्याय है, जिनमें लास्ट में वे बताते हैं श्रेयसी प्रजार्थम। ये पूरा जो मैंने वर्णन किया शारीर स्थान में वो इसलिए किया कि श्रेयसी प्रजा उत्पन्न हो। तो थर्ड ट्राइमेस्टर इज वेरी डेफिनेटिव, और उसमें अगर, क्योंकि ये विश्व मंच से मैं बात कर रही हूँ, तो मैं ये बोलूंगी कि महिला जो है उसको आप अपना क्या बोलते हैं हम लोग, ये बेचने की चीज न समझते हुए जो आने वाला ह्यूमन बीइंग है उसकी अहमियत, उसकी इम्पोर्टेंस समझते हुए हम ये सब चीजों से उसको लादने के बजाय इस तरह माँ अपने मातृत्व का आनंद ले पाए और जो जन्मने वाले बच्चा है वो बच्चा स्वस्थ जन्मे, इसके लिए हम अगर ज्यादा उत्सुक हो, ज्यादा प्रयत्नशील हो, तो शायद हम अपना ह्यूमन होने का, मानव होने का कर्तव्य निभा रहे हैं, ऐसा हम अपने आप को संतोष दे सकते हैं। थैंक यू सो मच आयुष दर्पण, थैंक यू सो मच शिल्पा मैडम, थैंक यू सो मच शर्मा साहब, और सभी दर्शकों को भी बहुत बहुत आभार। आपको अगर प्रश्न पूछने हैं तो पूछ सकते हैं।
Thanks, ma'am. Really nice, wonderful presentation with enlightening thoughts of Ayurveda, concepts of Ayurveda. And any questions, doctors, you can ask, please. Very nice, as usual. Yes. So with this, I would like to welcome our next speaker, Dr. Dipti. Dr. Dipti Godbole ma'am, who is associate professor in the Department of Rachana Sharir in SDM College of Ayurveda, Bangalore. So welcome, Dr. Dipti, once again.
Thank you, ma'am. Thank you for giving the ground to speak a few words and share my thoughts today. Ma'am, am I audible?
Yes, yes, please continue.
Okay, ma'am. So on the National Ayurveda Day, I'm here to speak on a clinical anatomy aspect. So as we know, happy National Ayurveda Day to all of you. So we have to promote and disseminate our science globally and create a global scenario for the welfare of our mankind, animals, plants. So this is our motto, and in this motto, so we are going to talk on topic on clinical anatomy of the uterus. So only the clinical anatomy. So what is taken by my part, only I'll be going through that. I'll not be going into the details of anatomy of the uterus and all, because all are Vaidyas in this. So you'll be knowing about that. Let us try to focus on the clinical aspect of that. So let me share the screen so that. Ma'am, is it?
Yes, please continue. Yes.
Yeah. So, fine. So as we all know, this is a secondary sexual organ. Then we also call it by the common name as womb. And next we also call it as hystera. So these are the other names for uterus. This is a thick muscular organ capable of expansion or distension to accommodate a growing fetus. We know this. So then just I want to summarize, like distally there is vagina, and laterally there are uterine tubes. Then there has three parts. Fundus is the topmost dome-shaped part. Then the major part is the 2/3 part is body, and the lower part, distal part, will be the cervix. So you know about these things. Now you see the location. If you see the location, so posterolaterally we are going to find so the bladder and then rectum in front of the uterus. So at least this basic knowledge we should have. So when we are speaking about the clinical anatomy aspect, and this also your familiar size variation, how the uterus will vary in shape and size in different phases of a woman's life. So before attaining menarche, so it is 2:1 ratio, cervix to body ratio. So same is the case when the lady attains some menopause or even post-menopausal, it is the same. So it becomes reverse when she is in the reproductive age. That means today cervix will be 1 and the body ratio will be double of that. So it is 1:2. So these are some important things that you have to know. And what are the normal positions we have in the uterus is, one is anteverted, one is anteflexed. So commonly we describe it as anteverted uterus. That is the most common presentation that we get to see it. So where with respect to the vagina, it is anteverted. With reference to the cervix, it is anteflexed. Okay, so these are the things we have to be knowing about when we are going for a reading of a scanning report or when we are going for diagnosis of a hysteroscopy report, etc. things. Fine. So coming to the clinical importance from the beginning itself, like for example, just now I told antiverted and antiflexed. So what are the clinical relevances you get in this regard? So sometimes the common dispositions may be in the form of excessively it may be antiflexed, excessively it may be retroflexed or retroverted, and antiflexed and anterolateral. So different words that you're finding here are retroverted. So combination, see the combination, it can be antiflexed and retroverted, retroflexed and retroverted, or excessively antiflexed. So commonly, majorly, we find these are the common dispositions or the presentations that we find as a variation. So this is also to be known. Then if this is the condition, then we can also have the uterine prolapse. So prolapse is there in this condition if it is because retroverted uterus is there, which in relation to the vagina, intra-abdominal pressure when inside, because of that there is sagging of the uterus more likely into the vagina. Because of that, the woman will undergo the uterine prolapse, 1st degree, 2nd degree, and 3rd degree, like that. So this is the simple diagram of what is the normal position. So superiorly we are having bladder, behind we are having the vagina, in between we have the uterus. So this is the antiverted position, and there is the retroverted from behind. So this is the normal presentation. Next, we have the histology. Like you must know this also, like what is myometrium, what are the layers of the uterus. So peritoneum is, once again, we are familiar with the word peritoneum, double layered membrane. So which is continuous with abdominal peritoneum. So those which are going to cover the abdominopelvic organs, we are going to call it by the name as peritoneum. Myometrium, myo is muscles. So the thick muscular layer we are going to call as myometrium in reference to the uterus. And the most innermost part we are going to call it as endometrium. So endometrium is again into two parts, deep stratum bassalis and deep stratum functionalis. So these are important things to know to find the clinical diagnosis of this. Now quickly let's go to the important clinical this one anatomy. Like let's start from the congenital parts. So see, this is the leftmost part is the normal uterus. So next there are different presentations: didelphys uterus, arcuate uterus, septate uterus, bicornuate uterus, unicornuate uterus. So diagrams only will explain you. So didelphys means there are two. Okay, there are two, and there is a dip in the middle. So then the fundus, when you are seeing the fundus is not continued in the middle part, it is dipped in the central part. So it resembles like a heart-shaped uterus into two parts. Okay, double-sided, and it's look like a heart-shaped uterus. So we use the word there as didelphys. Arcuate uterus, you can see a small dip is there in the middle of the fundus of the body of the uterus. There's a small dip over this that we call it as arcuate uterus. Septate uterus is septum. There is a clear-cut demarcation in the midline. So that is when we use the word as septate uterus, septum, because of the septum or the demarcation in the midline or the partition in the midline. Bicornuate. So bicornuate is, again, it is divisible into two uterus. Unicornuate is single-sided uterus. So whatever I have told, so sorry, I was wrong. A heart-shaped uterus is bicornuate. Didelphys is double uterus. So you can see in the diagram, double uterus, one on the left and one on the right. Bicornuate is when it dips in the middle. The fundus, when it dips into the middle, it is going to resemble the heart-shaped structure. So we use the word there as bicornuate. Absent uterus. Absent uterus can also be known as agenesis. So A is negation in anatomy. So agenesis is when there is an absence of the uterus from the beginning or because of loss of development. We use the word there as agenesis or the absent uterus. So these are different malformations that usually happen congenitally. So these are more important in the clinical aspect, congenital anomalies rather than the acquired one. So because of these congenital anomalies, the female can have infertility or problems during pregnancy period also. So other than these, apart from that, she can also have the fallopian tube defects, cervical defects, or the upper vagina defects in these areas, or malformations in these areas. Fine. So there is one more malformation which we call it a dysmorphic. This is something which is not properly situated in position. So dysmorphic, this looks, so from outside we can see it as normal in appearance. So from outside it looks very much normal, but from inside there is a change in the uterine cavity. There is abnormal uterine cavity. So that is why it presents in two forms. It presents as T-shaped uterus, then it presents an infantile uterus. So how do you understand T-shape? Just look at the diagram carefully on the left side. T-shape, it is in the form of T-shape because 2/3 to 1/3 ratio. The corpora means the body of the uterus is 1/3 part, and the one-third part is only the lower cervical part. So that is how it looks like a T-shaped uterus. So reverse one is 1/3 is corpora, 2/3 is the cervical part. That is where we call it as tubular infantilis. So see, these are the different forms which we see under the heading of dysmorphic uterus. So from outside they look same in appearance, but there is a problem in the abnormality in the uterine cavity. So this ratio is important to be remembered. Okay, so this is what I have written here in the diagram. Okay, next we have clinical anatomy doesn't only mean, always keep in mind one thing. So clinical anatomy doesn't mean only that we have to find the pathologies or describe only about the pathologies, different pathologies related with this. So it also includes the different procedures of the surgeries even which we are talking, because we teach this first year children or PGs, which they also come under the heading of the clinical anatomy. So for example, I given the hysteroscopy, hysterized uterus. Scope is to visualize from inside. So we are going to use flexible tubes to see the uterus from inside. So this can be used as a diagnostic purpose as well as for the therapeutic purpose. So we can also diagnose the case, what is the problem with this hysteroscopy, because we can see the fibroid tumors which are benign basically. So we can see the fibroids where all they are present, and then how can we make tell it as therapeutic, because if there is excess bleeding, then we can even prevent the bleeding by destroying the tissue there using an electric current, freezing therapy, or the heat, or the different chemicals, using different chemicals. So these are the ways how we can prevent the bleeding by using the hysteroscopy. So it serves both as diagnostic as well as therapeutic tool as such. Another we have most commonly is colposcopy. Colposcopy is where we are going to visualize the uterine opening, which we call it as cervix and the vagina. So these are the two main structures we are going to see in colposcopy, and all the abnormalities, pathologies related with cervix and the vagina will be visualized clearly with this colposcope instrument. We call it as colposcope. The procedure we are going to call it as colposcopy. So what else we can do? So diagnosis is over. Then therapeutically, what can we do in this case? We can take a cervical biopsy with this. Fine. So this also serves dual purpose. Other than this, we have the different surgeries like myomectomy. Ectomy is something surgical removal. Ectomy is surgical removal. So what we are going to remove without the removal of the uterus here, myomectomy. So wherever there are uterine fibroids are there, so we are going to resect those areas, muscular areas. So muscle layer is myometrium. So we are going to remove those fibroids which are situated in that area, like myometrium, without the removal of the uterus. This is important. Without we are not going to do the hysterectomy there. We are going to do the myomectomy there. So other than that, we have again in myomectomy approaches, different approaches. Either we can go through the abdominal myomectomy, or we can perform the hysteroscopic myomectomy. So abdominal means by taking an incision, vertical incision, we can perform it as a laparotomy and do the myomectomy. The other way approach is by passing an hysteroscope. So previously I told you about the hysteroscope. So passing looking at the hysteroscope also, we can remove the smaller fibroids, specifically less than 5 centimeters, which are there. We can easily grab them and remove them. So these are the two things which we can on the day-to-day basis we are familiar with. Other than this, we have D&C and D&E. So very commonly this is done to stop the bleeding, or other than that, when there is miscarriage, after that, post that, to prevent the bleeding, we are going to do this. First, we are going to dilate, and then we are going to do the scraping. That is what we call it as the lower part of the uterus, cervix, where we are going to dilate first, and then we are going to scrape out the endometrial lining. So that we call it as curettage. So after that, if this, sometimes we also perform a suction movement. So where we use the word as dilation and evacuation. Okay, evacuation of the contents of the placenta, like that. So other than this, we have come across common another word is adhesiolysis. So lysis, killing of the adhesion. So recurrently, if the person is obese, if the lady is obese, or recurrently if she has more than 2 abdominal surgeries and all, there are chances of having too many adhesions for her. So in that case, we have to destroy those adhesions. Those we call it as lysis of adhesions or cutting of the adhesions. So that procedure we call it as adhesiolysis. So very commonly, this is also done during the time of other surgeries. So these are the things. So first was congenital anomalies. Second was there are also many procedures or surgeries related with this. And one more important thing is normal hysterectomy, which you know it is the surgical removal of the uterus. Usually postmenopausal it will be there. But sometimes if the case is like DUB, disuterine, functional uterine bleeding, etc. things, then it can be even removed before the age attainment of the menopause itself. So that is inducing the surgical menopause. Fine. So apart from this, we have many other clinical anatomies related with other things, anatomical perspective. So during the hysterectomy, see, knowledge of regional anatomy is very important, because just below that we will have the ureter there. Okay, so we can use the word there as water under the bridge. Water is the ureter. So kidneys, ureter, and then urinary bladder, what we have. So water is referred as the ureter for bringing the urine down, and then uterine artery is going to form the bridge. So when we are doing hysterectomy, we should be very careful for not damaging the ureters on either side. So water and the bridge is the phrase which always you have to remember for describing the clinical anatomy of this. So any surgeries we are doing, any procedures we are doing, very good knowledge of anatomy is always essential. Fine. Even to make the diagnosis, anatomy knowledge will help a lot. See, these are some of the things. Endometriosis. I'm not going into detail. I just want to highlight that how important is the subject for knowing the disorders or for doing the things or doing the surgery purpose. So from endometriosis, endometrium only, we have endometriosis, we have endometritis, we have endometrial hyperplasia, endometrial carcinoma. So many pathologies are there only in relation to the endometrium. So similarly, fibroids, if they're there in the myometrium, so that also can be related with the myometrium. So where you will know it's a thick layer of the muscle. Then we also know that there is adenomyosis, right? Adenomyosis is there. Then we have fibroids, different types of fibroids, intramural fibroids, etc. things, myometrium, these things, leiomyoma. So we usually these fibroids are benign in nature. Okay, so they affect 20% of menopausal women, which is the incident that you have to remember. There are many causes for this fibroids. If it is too big, if it is giving a lot of pain, okay, if it is the compressing the nerves, so if it is so bad, causing so many symptoms, then definitely there has to be the surgical removal of that. For fibroids. Otherwise, we can even manage with the medicines if the lady is asymptomatic. Okay, if she's asymptomatic and if it's not giving too much of trouble, then we can manage even with the medicines as such. Okay. So these are some of the insights that we have to know for this. Uterine polyps can also occur. So smaller polyps to bigger polyps also can be there. So this is also depending on the same reason. Asymptomatic, painless, if it is there, nothing to worry. So as long as it is going to trouble or more symptoms are going to be seen, only then we have to do the surgical removal of the uterine polyp or polyps. Okay. Then the last we know is uterine cancer. Usual presentation of this uterine cancer is in the form of endometrial cancer. So drug induced, which drug induced? Tamoxifen. Okay, tamoxifen will increase the risk of endometrial cancer. Other than that, if too many hormone replacement medicines are used, then also it will be seen. Other than that, early history of PCOS, if it is there, obesity, if it is there, bleeding after menopause, if it is there. So all these are the different causes for having the uterine cancer in the form of endometrial cancer. So I thought this would be sufficient because the time given is very short. 10 to 15 minutes is what has been told to finish the presentation. And I think in that this much is enough. So see that you systematically always study the clinical anatomy like this for any set of organs. So you read it in the form of different procedures, different surgeries, congenital anomalies, and then pathologies as such. So that will help you to systematically diagnose and treat the cases. So I thank from the bottom of my heart the Ayush Darpan Foundation, Dr. Naveen sir, Naveen Chandra Joshi sir, and also Dr. Shilpa ma'am for giving me a platform to share my insights on this topic on today's National Ayurveda Day. Thank you once again very much, ma'am.
Thanks, ma'am. Though the time was allotted time was less, but still it was really nice to hear you after long. And I just want to ask the question:
Yeah.
what we, how can we deal with the double uterus?
Yeah, that is once again a congenital malformation.
Uh-huh.
Mullerian
Yes,
duct, because of the underdeveloped Mullerian duct, so it will be seen as didelphys or like double uterus on the sides. So there is no other way in managing the medicine. So again, we have to do the surgery and correct it.
अच्छा, okay.
Didelphys.
Yeah. So,
So
मतलब ये सारे इसमें हम लोग सर्जरी करेंगे केवल सेप्टाइट
सर्जरी, हाँ
प्रोटीन.
मैडम, हाँ कंजेनाइटल जो भी है बिकॉज वो स्ट्रक्चरली एनाटॉमिकल डिफॉर्मिटीज के टाइप होते हैं. लाइक फॉर एग्जांपल सेप्टेट में ना डिमार्केशन बन जाता है बीच में पार्टीशन की तरह.
अच्छा.
बाइकॉर्नुएट में जो फंडस होता है, सेंट्रल पोर्शन ऑफ द फंडस होता है, वो डिप हो जाता है पूरी तरह अंदर तक. सो देन ओनली इट लुक्स लाइक ए हार्ट शेप्ड यूट्रस. सो
Okay.
जब ऐसा स्ट्रक्चरली प्रॉब्लम होता है, एनाटॉमिकली स्ट्रक्चरली प्रॉब्लम होता है, then there is no other option other than doing the surgery in these cases.
Yes, ma'am. Ma'am, is it transferable? That means next generation में अगर बेबी गर्ल है, किसी महिला को हमने ये सारा सर्जरी करवा कर if she gets pregnant, then what are the chances of?
So as per the books say, they are very rare, they say. Even these congenital anomalies which are there are not very common. So they are rare. Usually they are rare. Incidence itself is rare. So,
Yeah.
but if it is there, but if it is operated before time and all, I think it should not be there. That risk should not be carried for the next generation.
Yeah. और हम लोग इसको कितनी मतलब साल तक कर सकते हैं एट द एज ऑफ 40-50 ऐसा कुछ वहां पे ये है सर्जरीज के लिए कोई इंडिकेशन है क्या स्पेसिफिक कि इतने साल तक अगर सर्जरी करते हैं तो प्रेगनेंसी के चांसेस बढ़ेंगे और नॉर्मल रिप्रोडक्टिव लाइफ के लिए ऐसे कुछ है क्या मार्क्स?
ऐसा तो नहीं है मैम, बट like they have given the moment it is diagnosed, it's better to operate so that we can avoid the risks which are coming in the pregnancy period करके.
अच्छा, okay. Early diagnosis is
always the better one. So when we do the diagnostic scanning in the early days of pregnancy, so when we get to know that.
Yes. Any more questions, doctors? डॉक्टर शशि और कोई डॉक्टर, अगर किसी को कुछ इसमें ऐड ऑन करना भी हो या पूछना भी हो तो आप पूछ सकते हैं प्लीज. Any more questions?
And one more common surgical thing what we perform is cesarean section in relation to the uterus. That's one more common thing I not added in the slide. Now I remembered it.
Yes. So you have to do a cesarean section most of the time for such type of cases.
Cesarean section, that's one nowadays that is only becoming more. No one wants to take the pain. And obesity, lifestyle disorders are there. One or the other risk factors will be there, either obesity or hypothyroidism, dyslipidemia. So all these are under control, or diabetes, type 2 diabetes. So in these cases, gestational diabetes. So usually cesarean will be performed in such cases.
Yes, of course. Yes.
And excess amount of liquor or less amount of liquor, placenta previa, any such risk factors are there.
मैम एक जस्ट वन लाइन या आपको जैसे भी इसमें प्रकाश डालना हो तो प्रेगनेंसी में फाइब्रॉइड्स अगर हो तो हाउ कैन वी डील विथ, इज देयर एनी करेक्शन, सर्जिकल करेक्शन?
Surgical correction, that's what they do not want to take the risk, but if it is too much then they have to remove the fibroid. If it is too much symptomatic,
big size,
but compression ज्यादा हो रहा है, abdominal pressure ज्यादा हो रहा है, like obesity भी है तो करते हैं, नहीं तो इतना normally asymptomatic होता है अगर ऐसी
Mhm.
परिस्थिति है, वेट ज्यादा नहीं है, like if that is the case, then also they will be managing with the medicines.
ओके ओके या ओके, चलिए वेरी नाइस मैम, अच्छा लगा।
Yeah.
थोड़ा टाइम कंज्यूम ये था, बट जैसे कि पार्टिसिपेंट ज्यादा है और आजकल जैसे लोगों के पास समय भी नहीं है, सब बिजी भी है, और आयुर्वेदा डे का सेलिब्रेशन हर जगह चल रहा है, सो फॉर दैट पॉइंट आई हैव जस्ट allotted
No
less time.
problem.
Yes, yes. Okay. Thank you very much, all the participants and doctors and today's speaker. And we will meet again on Monday with the new speakers and new ideas and new theme. So तब तक के लिए आप सभी का बहुत बहुत आभार, और फिर मंडे को मिलते हैं हम लोग नए स्पीकर्स के साथ। थैंक
Thank
यू
you.
मैम, थैंक यू,
Thank you.
थैंक यू, बाय।